My name is Cassandra. I am a registered nurse practicing out of the Midwest. And through my bachelor's completion program, I was able to do a research project titled Bridging the Language Gap, Evaluating Language Access Training for Healthcare Professionals and Students. This kind of want was born out of an observation that I made in my own field of work. I have 10 years of experience as a medical interpreter. So this is interpreting in the medical setting. And through that, I saw a gap in communication or care gap really, between our patients that were linguistically diverse and the medical staff that was caring for them. So then in my own education, nursing school, I noticed that there was a gap in um, the exposure and amount of time that we spent on this topic in our literature. So I wanted to see if this was a unique experience to me and my education, and then also if there was training, how effective is it? How are these language barriers affecting patient care? And then what improvements might be needed to enhance language access? And because I do have a special interest in language access, I wanted to share this presentation. We know that effective communication is central to safe and equitable healthcare. Um, Yet, in the research that we already have, healthcare professionals and students report minimal training in working with interpreters or supporting linguistically diverse patient populations. A lack of early exposure or structured education can contribute to safety risks and perpetuate healthcare disparities. So I want to pause here and kind of insert a narrative, which is in an acute setting, right? We have a patient with a language barrier. And if we don't know how to quickly access an interpreter or the language access resources that our institution has, then we are wasting valuable time. That can really make a big difference and a big impact in the patient's outcome. Whether that is a delay in care because we're waiting for an in-person interpreter or we're waiting to figure out how we're going to communicate with this patient. Um, and then also, is it a comfortable thing for our staff to be doing? And I say that in the sense of if this is in the real field, in acute setting, say maybe the emergency room, this is the very first time that you've role played through what that experience is going to look like, what it's going to feel like. It can be difficult. And as an interpreter, I've met many nurses and providers who've come in and said things like, can you tell them, or can you ask them, or can you find out if, and really that communication should just be direct, right? Staff should communicate with that patient like they would any other patient. And ideally, that encounter would go just as smoothly as it would with any other. But you do have that kind of like filter or veil of the unknown. So the research questions that I set out to answer were how effective is training for students and health professionals, nurses, MAs, providers, etc., in preparing them to communicate with linguistically diverse patient populations, and how are language barriers impacting patient care? What improvements might be needed to enhance language access training? And really the overall picture that I was trying to paint was, is it happening in the first place? Because it didn't happen for me in my nursing education. Um, and if it is happening, when's it happening? Is it happening during the secular exposure or experience? Is it happening on the job? Is it happening during orientation? Is it happening um, post-graduation, pre-graduation? When was it happening? So I was able to divide that up into the chart that you'll see in my results here: non-formal training, training before graduation, clinical training. Most healthcare uh, certified or licensed healthcare professionals will have some sort of clinical period where they have to basically go into an institution and practice as they would if they were certified or licensed. And this is like a real physical experience. This isn't a sim lab. And then on the job training. So that might look like orientation or just kind of happen to you as you were working. I do also have this other section as part of the bar graph, and I just want to note for the sake of transparency that this data or display is inflated. And I say that because out of the 10 that selected other, there was an additional question that required them to list what that other was. And only 3 of those 10 out of the 150 some submissions for this particular question, only 3 of them listed that experience. And you'll find that down below in the text between the 2 charts where it says other training responses other training responses included prior military or social work experience, bilingual fluency, self-guided learning, and online modules. And that, in hindsight, I maybe would have removed that, but the research that I did about research, because again, research is new to me, this is the first time that I've done it, indicated that for the sake of transparency, I should leave that as part of the graph. And then I guess I'll just back up a little bit. So the way that participants were recruited was through email, social media, flyers that were distributed in local areas, the schools, healthcare setting, and then the eligible participants included nurses, MAs, health providers, and students enrolled in healthcare education programs. I used a mixed methods approach from consent to finish. I had about 16 questions, and this online survey incorporated both quantitative, multiple choice questions, like scale, and then qualitative. So these were short answer questions that were in free form. They had to be typed in. And these questions explored participants' experiences with language access training, preparedness to communicating with linguistically diverse patient populations, and then the perceived impact on language barriers in patient care. All answers were analyzed anonymously. Participation was voluntary, and informed consent was obtained electronically prior to beginning the survey. So back to our data and results. In the proportions of participant requesting additional training, this was a surprise to me. I was not surprised by the relationship between training type and perceived confidence, which was that those that had exposure prior to graduation had better confidence levels than those with no formal training, clinical training, or on-the-job training. That is not a surprise to me. That is a suspicious or hypothesis that I had, and I'm happy to see it because I feel that even in its small form, it definitely reinforces the idea that we should have more structured training requirements about this topic in the educational time period of healthcare professionals. And this request for additional training surprised me because we are all very busy. Whether you're a nurse, an MA, CNA, or a provider, I think you probably feel that you are doing the most. And it isn't this like stagnant attitude. We do sometimes have some bad apples that just want to be done with school, but we're always learning, right? And medicine is fluid, so there's always new things, new facts, new data, new research. So it is exciting to see that the majority requested additional training to working with interpreters and or basically diverse patient populations. And then you can read those kind of comments from that group, but I thought that was pretty exciting. So with any research, there's always limitations. And it's important to just kind of review those quickly, which is that the study relied on self-reported data, which is why those are perceived confidence levels, right? We don't know um, if that reflects, right, actual preparedness. And then the sample was disproportionately composed of nurses, 97 out of 175, with fewer responses from providers, 38, support staff, 11, so CNAs, MAs, and then students totaling 9, for which identified as students in the free text option. This role distribution may limit this ability to kind of generalize across the broader healthcare workforce, but it's still notable data, right? I think the overall findings still offer valuable insight into the preparedness of training needs and individuals across the healthcare field, which includes students, recent graduates, and then practicing professionals. Some participants were recruited through snowball sampling, which may introduce selection bias, and then those open text responses were manually coded and may reflect researcher interpretation. Um, I would love to do something else with this data and make it more available in its raw form. Love to get feedback. So if that's something that you're interested in, please reach out to me. I would love to work together. And then lastly, I also kind of wanted to note what was exciting to me, which was that of those 175 participants, the majority of them were from the Midwest area. But I did have participants from California to New York submit a response. These were collected through a kind of spread the word um, um, dissemination. I'm not sure if that's the right word, but I think it is. Um, yes, maybe. Anyway, um, that was exciting because I think that the fact that people are willing to engage with it from all over is really neat, and it shows that people care. People care about this topic, even though it might be difficult to understand. So again, if you have any questions, please reach out to me and share, like, subscribe.